Hello there, and welcome to this evening's webinar. I think we are live now. Good. So there are three of us speaking: Neil Nathwani, optometrist, senior clinical optometrist at Moorfields Eye Hospital with myself, veteran of the LIGHT trial, and co-organizer and coordinator of the Moorfields laser course for optometrists. Sheraz Daya, who was well known to all of you, a pillar of independent practice, refractive surgery, really pioneered a lot of the independent refractive practice and has broadened out and expanded his clinical offerings to in his hospital, and is bringing us a very a different perspective from that which perhaps I might give from my NHS practice of comprehensive ophthalmology and private practice, and how that chimes with the provision of laser care and care for our glaucoma patients. And then myself, Gus Gazzard, Director of Surgery at Moorfields. I was Service Director for Glaucoma Service. I was the lead investigator for the LIGHT trial looking at SLT, and Professor of Ophthalmology at UCL. Really just to introduce what we're aiming to achieve today, what we're going to cover, and then to give indeed my own first initial relatively short presentation. So I'm going to give a brief reintroduction to SLT. I'm then going to talk about some of the results from the recent randomized controlled trial, which compared SLT traditionally delivered through gonioscopy with direct SLT, the Belkin laser DSLT. Then we're going to be talking about some of the real-world experiences in a roundtable discussion with Sheraz Daya, myself, and Neil. And then Neil also has a case presentation, and we've got some discussion specifically around cases, and then some time at the end to field any questions from the audience that you may have. So do please send those in. Send that in on the webinar chat, or if you don't have access to that, to email, by email. Now, there are some polling questions. So we have a poll to begin with for you. Are you currently using laser as first-line treatment? Yes or no? How long are your waiting lists? And there's a choice of those for you. 1 to 3 weeks, 1 to 3 months, 3 to 6 months, or over 6 months. That's how long are the waiting lists for laser? And then what do you think is the biggest challenge when it comes to glaucoma management? Is it simply a matter of pressure? Is it patient compliance? Or is it actually somehow convincing patients that, in fact, what has been mandated by NICE as a first-line treatment is, in fact, their best first shot? Excuse the pun, sorry. So do please answer that, and we'll see what the results are as we go through. Just to let you know that towards the end of the webinar, there will be access to a pop-up quiz that you can either access immediately or do so after the event to get any CPD points for your relevant organization. So thanks very much for the preamble. If you will allow me to just kick off from here, and we will talk now just about a reminder of where SLT came from very briefly, because we've not that long this evening. A brief think about some of the evidence that bolsters its use, and then a look to see where SLT in its broadest sense might be going. So SLT was essentially invented by Mark Latina, and it grew out of a development in technology that allowed Q switching, which is the delivery of extremely short pulses of laser. And he was using a frequency doubled YAG that gave visible green wavelength light. And he had done a large number of initially in vivo and in vitro experiments looking at the effect of short pulse duration laser initially starting off with argon lasers and then switching over when technology changed, looking for the effects on the trabecular meshwork. Now, I think little known fact is that what Mark was originally doing was trying to generate an animal model of glaucoma, and the real stroke of inspiration was to realize that actually by really reducing the frequency of the pulse duration and not seeing an effect, he was actually lowering pressure and realizing that he wasn't creating some theoretical animal model of trabecular meshwork destruction. He was creating a model of increased outflow. And they varied the energy and used fine bubbles as an endpoint because people didn't really know what endpoint to take, and it seemed sensible to use something that was visible. That has subsequently shown to not necessarily need to be the case, and there's some interesting discussion around that, of course. And a decade passed where SLT had been around, but nobody in the UK was really using it. There was the odd laser around the place. There were some reports. There was a trial out of St Thomas's, and some very nice papers generated by the St Thomas's team, but nothing that really definitively kicked SLT into common practice. And I think there were many, many reasons for that, and we can discuss that if wished. And when I became a new consultant, we realized that actually SLT did work. We looked at the literature, but nobody was really using it. And so the task I set myself was to try and answer the question, okay, it seems to work, but should we use it? And could we even use it as the first choice treatment for patients? And then the rest is sort of 10 years of hard work and history, but we found that there was in fact a cost-effective pressure lowering from SLT, with over 3/4 of eyes and around 3/4 of patients controlled with laser alone at the end of 3 years, and then an almost similar result at 6 years. And that's led to changes in terminology and guidelines of the European Glaucoma Society now recommending that SLT should be considered. American Academy of Ophthalmology preferred practice patterns, and then probably most powerfully that the NICE guidance in the UK is now to mandate that we should be doing SLT. And then since that change in the guidelines, we've had more data. We've had 6-year drop-free rates of 70% in the SLT first arms, of around half of whom had needed more than one laser. We've had results showing that not only does it reduce disease progression, trabeculectomy rates, and seems to have a small difference in phacoemulsification rates, but that even after the lasers crossed over, even after you've allowed patients who started off with drops in this drops first arm, even they, when exposed, even when they were exposed and allowed to have laser, some of them still went on to need trabeculectomy. So what that suggests is that starting with laser is a very, very powerful, has a very powerful effect on long-term pressure control. So the earlier you use it, the better. We did also find, as yet unpublished but presented now, we did also find that a large number of patients, the SLT did work after they'd had medications for 3 years, but it didn't divert them off the track of needing trabeculectomy if they were already failing. Anyway, the hypotheses around it are that the SLT stimulates some cytokine release, there's cell recruitment into the trabecular meshworks, and a sort of cellular repopulation, stimulation of trabecular meshwork, stem cell division. Now, what's exciting about that, of course, is that it doesn't necessarily need direct exposure to the laser. And that's where the next real stroke of inspiration came from Michael Balkin, as you may know, an inveterate inventor, fizzing with ideas, hundreds of ideas a day, and some of those have really transformed and changed ophthalmology. And this is the one which has really had, I think, going to have an impact in glaucoma, which is that if you could create that same stimulation of cells and cytokine release because of a very low level of inflammation, because of very targeted absorption of energy within these pigmented trabecular meshwork cells without causing thermal damage and burning, maybe you'll be able to get the same pressure lowering effects, but without the need for gonioscopy, slit lamp microscope, and all the complexities of that. And then, of course, once you've got that, you can then have automated gaze tracking, automated laser delivery, and you can really simplify the whole process, as you can see here on the screen. It's worth bearing in mind at this point that the trabeculoplasty laser parameters are absolutely crucial to the sort of laser you're delivering, and that if you're talking about pattern laser trabeculoplasty or ALT or many of the various other forms of laser that are out there, you're effectively talking about the same sort of thermal energy delivery and heating process to the trabecular meshwork, which may well work at least the first time. But if you're delivering very short pulses over periods of time, and these are logarithmic scales here, over periods of time that are much shorter than the sort of thermal relaxation time for the melanin granules within these cells, that you will get with SLT no localized heating thermal spread of the energy, but with the heating cooking lasers you'll get a thermal effect and scarring, and as a result you may have much less repeatability of that laser. You certainly have much less for ALT. Clearly this is a very novel way of delivering laser, so it needs a lot of careful thought and safety investigations, animal models and rabbits, but also modeling of the energy delivery. That's been done. There have been some very elegant physical models of this to look at how the energy dispersal within the tissue arrives at the trabecular meshwork, to what extent of the peripheral sclera, the divergence rate of the incident beam hitting that limbal tissue, and all those similar variables affect the ultimate energy delivery at the tissue of interest. And what they've been able to show is that whereas a large amount of the energy reaching the trabecular meshwork in traditional SLT via the lens does actually get scattered at the various tissue and glass interfaces when that laser is delivered. Direct SLT also has some scattering, but it's scattering through tissue, and the similar amount of energy, the ultimate amount of energy reaching the trabecular meshwork from the two treatments is very, very similar, with the modeled amounts of transmission and the measured amounts of transmission that they've seen in vivo. So some very exciting physical underpinning for Mike Belkin's hunch. And then really the proof of the pudding was in the first in human studies, the published case report, ultimately leading to what is now a commercial entity with the Eagle DSLT that delivers 120 individual laser shots with a real-time gaze tracker that's able to follow any deviations and microsaccades. You're not reliant upon patient-centered gaze, and if they are to look off target, then the laser will briefly cut out and then start again. It's pretty much automated, and it's a very patient-friendly user setup. So the first randomized controlled trial was called Glorious. Several sites around Europe, Israel, Republic of Georgia, UK it was Belfast and Moorfields, and the aim was to demonstrate the safety and efficacy, and a non-inferiority trial with a 6-month time point with washed out pressures for both groups. The eyes had slightly raised pressures. We set a threshold IOP for re-intervention, randomized the two groups, and then took them through the study. Now, some of the eyes failed to complete follow-up or did not have, occasionally there were some that were removed because of incomplete masking, but the eyes that remained within the study and modified per protocol analysis looked carefully at those eyes that left or that were excluded, and they were no different from the main target group sample. And when you look at those, there was no significant difference in the pressure response at the 6-month primary trial endpoint washed out target pressure. Some of these pressures on this graph are washed out, some of these pressures are not, but the important one is that there were similar raised pressures in the mid-20s at the baseline, and then they were washed out to 6 months, and the DSLT and SLT pressures were similar. If you look at the proportion of patients that are drop-free, remember that they'd had a preset IOP target set, similar to the light trial, although more individualized for the patient and the clinician, but preset, and if a patient passed that target, then treatment was reintroduced. And there were very similar rates of drop freedom between the two groups, but particularly so for those who were untreated initially, so the treatment naive group, or treated on only one medication at the beginning. So we had no significant side effects or complications in the trial, so I think we can conclude that DSLT is safe. It produced a meaningful reduction in intraocular pressure at 6 months, sustained out to 12 months. I think we need larger, longer trials, and I'm looking forward to the fun of designing those. At 70 months, at 12 months, 70% of the treatment-naive patients are still drop-free at preset target pressures, very similar to that. We saw that with the SLT group. Remember that the SLT group in the light trial was slightly different from these. Some of these were pre-treated, but they were still all open-angle glaucomas. And then I think that we need to talk about how we might incorporate DSLT, what advantages it may have to us. One thing to finish with is that the COAST trial that Tony Riolini is running in the States, and $15 million invested in this study by the National Eye Institute, who are not known for their rampant generosity. And they've backed the idea that low energy SLT can be repeated annually. And I've probably gone horribly over time, but I think I'll take chairman's prerogative because I was only speaking. Now, the plan was to move on now really to a real world experiences with laser DSLT. Sheraz, were you wanting to share before we chatted? Are you?
Yeah, I can do. Well, thanks for inviting me to participate here.
Well, thanks for joining us.
And where am I here? Is this the one? Yeah. Can you see my screen there?
I can see your screen. Yeah.
You got the full screen?
You're now full screen with nothing else except the video, I think.
All right, good. Well, let me show the video then. This is real time, and you'll see the timer go on as soon as the speculum goes in. This is the sixth eye that I was treating on my first day. You can see the cameras are out there.
I just thought you normally had paparazzi following you around.
Well, I like to think so sometimes. Certainly when we do new things, eh? And that's now. So that beeping was the laser at work, and that took all of 30 seconds for one eye. And we did 8 eyes in the space of 25 minutes. And that was my first day. So I think this demonstrates how efficient the treatment is. Very quick, as you pointed out. It's we may actually have to have the patient sitting down. They can be standing up. Although I think it's a good idea to have a chair there just in case. Well, one of our patients went vagal on us between eyes, and he had to sit. Well, he actually had to lie down. So yeah, things can happen. It's usually the men that do that. This is we've just seen the patients 2 months later, and these are the pressures. The 2 patients had no drops, but had progression in their field and optic nerve, and we treated them. And 2 were on two sets of drops, but with 3 agents. And this is the reduction in pressure at 8 weeks. So going along with what you've said about no drops being a little bit more effective, this is a very small series, but it kind of demonstrates that. There are quite a few questions that people ask, are drops required? Well, 2 of our patients were photophobic for 3 days, but we didn't put them on steroids. It doesn't hurt. The patients feel like there's a bubble or something pops in their eye. One patient more laterally moved, and it was quite interesting to see how the laser tracked them, and they moved back again and continued. Does it last? Well, yeah. I'll leave that to you, Gus, and it can be repeated. And what's really important, I think, is optometrists' involvement in this business, either, I suppose, doing it themselves or working with organizations that have the facility where patients can be treated and optometrists can follow them up in time to come. And that's really it. So not much to say. It's a very rapid treatment. The learning curve is pretty quick, and it's very doable. What attracted me to it is it's very futuristic, and it. I mean, I've done SLT. I have our other facility has an SLT laser, but I got to say, as anterior segment person who likes to get things done pretty quickly, it's a real chore to do. I'd rather somebody else do regular SLT, and now that we have DSLT, it makes a big difference. So it's something that we've welcomed into our practice, mainly as a service to patients. There are a lot of patients out there who come to see me for a second opinion because they're waiting for so long to be seen in the health service. They're worried about their health and they want attention. Well, we can provide that attention and more. I'd rather they come to see me then early rather than when they've got field cuts and then I have to send them to you, Gus. And I'm sure you're very busy already. So thanks for your attention. I hope that that gives you a glimpse of DSLT and as I say, I'm not really a glaucoma person. I do take care of glaucoma. I put tubes and other things because I create glaucoma, but I'm not, I don't want to be doing glaucoma day in, day out. However, it is a common condition. There are a lot of patients out there who need it. And in our type of practice, I think it's important that we provide a comprehensive eye care and provide them with technologically advanced care as well, which is why we've adopted DSLT. I keep saying I feel like an imposter in some ways, but our job is to make sure we look after patients as well as we can and adopt whatever technology is available to do that.
Yeah, well, I mean, I think that's why you're a very good choice of person to have on the webinar, because it's all very well having, I mean, I don't want to say ivory tower because Moorfields may be ivory coloured in the photo, but it's not really an ivory tower. But it does have certain advantages. We're very, very subspecialist in what we do. And it's all very well having us talking about it. But actually, you do see a whole range of patients out there in a much less subspecialist way. Neil, do you want to, before we have a sort of chat back and forth about the role of optometry, do you want to talk about your case or your experience first, which you'd like to do?
I think cases shortly after, but we can talk about the experience, my experience with the DSLT so far. So firstly, thanks for the invite to talk here today. So I've been doing SLTs in the NHS in my clinic for around about 4.5, 5 years nearly, and done plenty of SLTs over that time. And then we've been doing the DSLT over the past few months as an alternative. So my experience so far, so similar to what Sheraz just showed with the video, actually, patients, standing on the machine, and as he said, I sort of have a chair behind in case it's needed. And also when I'm switching between the eyes, once I treat one eye, I get them to sit down, pop the speculum into the other eye, and then stand back up again. So just as a, just for ease, for giving them a minute or two's break between the eyes, and then switch over to the other eye. The instrument is quite, as he showed on the video there a moment ago, quite self-explanatory in terms of you just focus up the machine and get the eye in focus, and then literally just clicking next, and the machine does the job for you pretty much. And that eye tracking is very useful because sometimes when the laser does, activate, the patient does have a, slight sensation. And then sometimes, obviously, if they've never had laser before, they don't know what to expect. They might move slightly. But that's when the laser sort of pauses for a brief second, and then until that patient sort of realigns their eye with their fixation target, and then the laser starts to zap away again, and then it also produces quite a nice report at the end showing where the laser spots were delivered and how many spots were delivered as well, actually, because if there is a large eye movement, it sometimes skips out some of the spots and it doesn't want to laser in the wrong place. So similar to what Gus said earlier in terms of it delivers 120 shots, but then if there is a large eye movement, it might end up delivering 115 shots. So but then you can sort of see, and it sort of does a nice little playback on the video as well in terms of in a slow-mo showing this eye movement. And then that way you can sort of see that how much of a movement it was and where the shots were skipped by the machine due to obviously safety if the eye movement was a large one. But I always sort of say it's Gus will probably agree or disagree, but it's all about patient explanation. So whenever I'm doing the lasers, I always sort of take the extra moment to explain to the patient what I'm going to do. Take that extra moment to explain what to expect, what's coming, and that way the patient's going to be more sort of compliant and be ready for that laser treatment. And in that way, it's going to be a bit more of an accurate measurement as well with the 120 full shots delivered. But it's quite a straightforward treatment. And I always sort of joke with patients as well that it takes me longer to do the paperwork and writing the letters to the GP, etc., than the actual treatment itself. So, and they're always quite surprised at how quick it is. So it's quite a quick procedure, and patients tend to be quite surprised at how quickly it's done, and then always at it. That's the usual 3 words that they say afterwards. So personal experience so far has been pretty good in that aspect in terms of the speed of the treatment delivered. Thanks, Gus.
I mean, certainly it's been very easy to incorporate and integrate into our setup and our practice at Moorfields with the problem. We're currently auditing the first 100 cases. That's not a trial; it's an audit, but it's a safety audit, and it's proceeding smoothly certainly without any hiccups. I do think it will be interesting to have further trials and further studies once this is more widely disseminated, and getting the results that I just presented, glorious trial results, out there in print with proper peer review rather than just me just presenting the meeting. So I am looking forward to that shortly. Neil, do you want to present your case? Because we've seen a couple of Sheraz's case series. It's always nice to see some individual details. I mean, I know one swallow doesn't make a summer and one case series doesn't make a change in practice, but it is interesting to see.
Okay, yep, fab. I will share screen. Give me a second.
And you're hearing me tapping away because I'm just answering some of the questions that have come to the panelists. One of which was, do I think that the panel think that DSLT laser will be a high street delivered treatment, not even triggering onward referral? Well, I think I would sincerely hope that anyone firing laser at my patients or nearest and dearest would be at least qualified in the sort of the glaucoma sphere, making appropriate judgments and careful nuanced decisions around treatment and not simply firing off at pressures. Now, that's not to say that that can't be done, but I think that there is certainly a role for some degree of, if not subspecialist fellowship training, certainly a role for individuals who've got subspecialist glaucoma training. Now, some of that is achievable clearly with the higher certificates and diplomas and very high bar that needs to be passed to get that, along with a demonstration of clinical experience as well. So I think I do see a time coming when patients may well be coming to certainly to centres like Moorfields or specialist fellowship trained glaucoma specialists, having already had a couple of lasers and been hopefully carefully monitored for a few years. But that's my personal view. That's not necessarily the view of everyone. Sorry, Neil. I'm just waiting on to give you a chance to get settled. Do you want to?
That's fine. Also, I'm ready now. So thank you. So the computer's actually loaded up now, and it's hopefully should be working. So this is a 1K patient that I did a DSLT treatment on. So I'll just go through the journey that this patient went through post SLT. So it's a patient who is a relatively young 58-year-old male IT professional, Caucasian race, driver, general health quite good, just arthritis and migraines, no medications, and mother having glaucoma. good vision with glasses, no drops initially, so it's a new patient to the clinic, and the pressures on the aura, the IOP-CC, was 24 in the right and 29 in the left, with slightly asymmetric CCTs measured in clinic. These were their visual fields. So right eye, pretty much a full visual field with a reliable indices, and then left eye with a field defect there, again, a reliable visual field there. Before this starts in 2022, April 22 actually. This is just a visual disc OCT of the patient's eye. So left eye showing more damage than the right. The diagnosis given to this patient was right eye POG suspect and left eye POAG. And the outcome from this review was that the patient was started on latanoprost on the left eye only by the treating clinician. They were then sort of seen a bit more of a delay than usual, to be honest. 6 months later, visions are still good. Obviously, so right eye, they're not taking any eye drops, and they're taking the latanoprost in the left eye. So the pressures have dropped. Right eye remains at 24, so remains at the similar level to what they were at the beginning. But the left eye has dropped quite nicely. If I just go back a slide or two, it was 29, it's gone down to 19. So right eye remained at 24. Whereas the left eye has gone down to 19 from 29. So a good reduction. And the plan was to continue with the drops in the left eye at this good pressure. And the clinicians decided to start the patient on the drops in the right eye as well now, but then at the same time list them for bilateral SLT. So then they end up in the clinic. This was the laser clinic itself, actually. So the visions are still good. They're taking latanoprost as instructed in both eyes now. And the pressures with eye care was 9 and 12. So just note that this is the eye care rather than the aura. So it's a different machine this time around. So we don't... so obviously the eye care, the aura previously on the left eye was 19, and remember on the right eye we've had a change because they were on 24, but they weren't taking the latanoprost, but now they're taking latanoprost. This was an eye care measurement prior to the DSLT being done. So prior to the DSLT being performed by myself, we popped in some stat iopidine prior to the treatment. They ended up having both eyes treated on the same day. 120 shots were delivered, so we had full treatment at 1.8 millijoules, and that's the total power delivered per eye there. We make the patient wait around about 45 minutes to an hour for a post-DSLT or post-SLT pressure check, just to make sure that they've not had a pressure spike. That's one of the relatively rare occurrences post-treatment. So post-treatment, you can see the pressures are fine, so they did not have a pressure spike, and they were safe to be let them go home afterwards. And that was, again, remember the iopidine, just to prevent that spike happening. So plan was to then review them in 8 weeks' time for a pressure check in clinic to review the outcome of the laser treatment. And I sort of advised the patient the plan was to stop the latanoprost and see how well the laser treatment's done. So I asked the patient to stop the latanoprost in 6 weeks time, so 2 weeks prior to the appointment, the follow-up appointment, so we can see how well the lasers worked. So I came back to clinic. This was back to normal clinic. A couple of months later, again, vision is still good. With the glasses, they've stopped taking the drops as instructed, and the pressures are 16 in the right and then 23 in the left. So the outcome or the summary from this was that the pressure in the right eye is good, considering the pre-treatment 24. Again, we've got the aura measurement here again, the IOP-CC, so we've got like-for-like comparison on that. So it was from 24 to 16. The left eye, however, there's still a reduction from 29 to 23. However, the clinician thought that it's a relatively young patient, 58, with a field loss and that family history. They felt that the 23 was too high for this patient, and they decided to start them on latanoprost in both eyes again, as we know that it does work rather well for them with the previous measurements that we've had done for this patient, and to see them back again in clinic in 4 months' time. And this was literally a couple of weeks ago, actually, wasn't it? So they're seen back in clinic, and the visions are good again, still with the glasses. They're back on the drops as instructed. And the pressures on drops plus the DSLT treatment, which was now 6 months ago, 12 and 13. They had a field test here. The fields are stable, again, slightly unreliable on the right eye, but reliable on the left. Fields are pretty much the same. But the main take-home point for this one is that the patient's got nerve pressure in the low teens, with the starting pressure was 24 in the right and 29 in the left on the IOP-CC, and they are hopefully doing well. So the next review is going to be in 6 to 8 months. So that's sort of April, May time, hopefully, for their longer-term follow-up and outcome with the pressures. So they're doing rather well with the drops plus the laser treatment so far. So that is a patient that I literally lasered 6 months ago. So good. Thank you, guys.
Thank you. Thank you. No, it's nice. It's nice to have a real patient to deal with and something concrete to hear. Sheraz, are you going to think you're going to have optometrists delivering laser in your centre?
We don't have any optometrists that are UK qualified. We have ones that are imported from other countries, so I don't think so. What we would like is we're an open access centre. We would like glaucoma specialists to bring their patients over, treat them, and look after them on their own. I think there's a role for a heavy role for shared care in optometry, and we would like optometrists to take care of glaucoma patients in the long term. There's just too many of them, far too many for ophthalmologists to deal with, and to share care and to be a point of contact. But they will diagnose these patients and send them on to us for verification and treatment, and we'd like to send them back for pressure checks and visual fields and nerve fiber layer OCTs and so on. And then where they start to deviate, we see them again and intervene further if necessary. But I think that's the sort of role I see specialty ophthalmologists and even comprehensive ophthalmologists doing. We've got the technology. We'd like it to be open access for all ophthalmologists who want to come and do SLT without having to fork out for a device until they get volumes that are sufficient enough to justify it. But I'm more than happy for them to come and use our sites, and also, but yes, take your patients away with you and look after them. Or optometrists, feel free to work with us in some sort of shared care environment. What do you think, Neil? Do you think that that's a good option for optometrists, since you're a treating optometrist yourself?
Definitely. So I think over the years, optometrists have become more involved with, treating, managing, taking care of patients compared to what was happening 10, 20, 30 years ago. And, so when I still remember when I treated my first patient with SLT, 5 years ago, whenever it was, that was a big step for me. Because, traditionally optometrists, we, in our undergraduate training, we don't treat patients. We pass them on to ophthalmology for treatment and management. So optometry is in my opinion, going in the right direction with the shared care. And as you say, there is a lot of glaucoma around. So, and it's only going to get worse, isn't it, with the aging population? So I think there is definitely an option there for optometrists to get involved. But as we said before, though, I always sort of say that it's got to be managed properly, though, in terms of the right candidates, the right qualifications, the independent prescribing, the glaucoma qualifications, as well as the ability and the clinical experience that goes with it to manage the rare case or the odd case that does happen with a weird and wonderful complication. So, or knowing where to go or who to contact or how to manage them things. It's all well and good having the straightforward cases and that all go well and we're all happy, but then there is always that odd one that does surprise us. But so it's all sort of good, but not to be negative, but also have that sort of protocol guidance, sort of that fallback option, if you
right.
can call it that.
Yeah, I mean, I think I do think SLT generally is something that opens itself up to very simple protocolized treatment as first-line treatment for most, if not all. The rates of sight-threatening complications are extremely small, but they are there, and they do need ready access to treatment. But then again, there are many things that there are rare side effects and complications that are done widely that need ready access to prompt treatment by an onward referral. That doesn't necessarily mean you have to do it yourself. You just have to be able to identify it yourself. Something that's going to be very interesting to see how things may change. I think one area in which, Neil, my experience is different from much of the country is that we are relatively short waiting lists. So we really can treat patients within a few weeks from their new diagnosis. And we see some people who have been unable to see a glaucoma consultant for 2 years and have, waited many months with very high pressures for standard surgery, which is a shame. So I think bringing down the waiting list and prompt, efficient, rapid, high turnover, safe treatment is really going to be the USP for this. Somebody said to me the other day, he said, but is it better than SLT? And I like SLT, and is it better? I don't think it needs to be better. I just think it needs to, be as good. Because there are so many other USPs for it as a device. I'm not trying to sell it. I mean, I love my trials, and I want to see more trials, and I want to see more trials of this device. And in fact, there are a number of trials going on around the world. There's a trial of angle closure glaucoma in Singapore, where there's half of all the trabeculectomies are for angle closure. As I should know, I spent 2 years running a trial on trabeculectomies there. Well, what's interesting is could this be a way of actually accessing trabecular meshwork without needing to go across the anterior chamber and avoid the PAS? Could you actually treat trabecular meshwork in the presence of persistent irradiated trabecular contact or angle closure or peripheral anterior synechia? Will it generate enough inflammation to extend the PAS and make it worse? Or could you get some regain or preservation of TM function that you might not otherwise have? I think that's very exciting. And that's a trial I'm really looking forward to seeing, and other trials and discussions and interventions elsewhere. It's probably also worth bearing in mind some other things that we don't have laser traversing the anterior chamber. I've not yet seen a case of the occasional endothelialitis that we seem to get with SLT in very high myopes. I've certainly not seen that with DSLT. Whether or not we will, I don't know, but I've certainly not seen it. There are a number of comments. Sheraz, did you have any comments? I mean, there are a number of comments.
Going back to the optometry, that I think Neil's comments are absolutely on the button there. There does need to be. I believe that I like futuristic technology, but I like change. I like to see how we deliver care change. And from a utilitarian point of view, it makes a lot of sense for optometrists. But rather than maybe, I suppose, nurse consultants in ophthalmology could do it, but it makes sense for those who are well versed in eye care, who are the primary care individuals on the high street and city centers and town centers, to be looking after patients with glaucoma. But they do need that clinical experience. They're not going to get it when they're already trained. They can't all be going into hospitals and spending time there, but they can get that clinical experience by good liaison with establishments that have some sort of arrangement. So they've got that bailout, they've got somebody to contact, and it's seamless. And there's periodic CPD activities to keep them up to date, and also a forum for abnormal cases, as you point out, Gus and Neil. You've got the odd case where things don't necessarily follow what could be going on, and what can we all learn from it. And that's how we learn clinical medicine. So I think it does need to be established, and it needs to be robust. But I really see that optometry has a big role in all this. And yes, they can use centers like ours to have the treatment delivered, maybe deliver themselves when when they get to that sort of level where they're dealing with glaucoma all the time, and then eventually adopt it on the high street or wherever is necessary. Wherever there are patients, we need to have therapies for them. So it's a point well taken. It'd be useful to have optometrists working in liaison with ophthalmologists, crafting out an ideal shared care network for glaucoma. But I think it does require that supervision to give optometrists, certainly who are new at the game, confidence in dealing with patients.
I agree. I think what I've also seen recently is since the laser training that we've been doing as part of our courses, as Gus said, we're quite lucky and sort of spoiled in a way at Moorfields that our waiting lists for SLT are quite low, but that's the availability of the laser clinics that we have open now. But when we've had,
because Neil's a total machine, so he just lasers everyone. So.
In and out. But when we've had, people coming from up and down the country for these laser courses for their training, and when you sort of speak to them, saying, just general chat in terms of what's your waiting list like, or who does the lasers in your hospital, and when you sort of hear some of the waiting lists and times, and it's quite a surprise to us who are sort of in our mini bubble, shall we say, where we're quite lucky in that aspect. So I think having what I've learned from them courses is having that, passing on that expertise and that training to the other clinicians, and then them going to their hospital and then being trained further and being signed off for laser procedures, etc. Having had that training with us as a starting point, I think that's been sort of a massive change for practice in certain instances, certain areas of the country. So I think just this adds to that as well, and sort of taking that one step further, we're getting optometrists, other healthcare professionals involved, and reducing that load off the service, and taking that pressure off the patient as well, actually, in terms of waiting with no treatment. And that's where I think having SLT, DSLT, and that shared care is really important.
Brilliant. So I think we're coming towards the end of this. There was a poll result that we had. Can we share that? Thank you very much. How long are we waiting? Well, under 1 week, almost no one. And 1 to 3 weeks, a few. 1 to 3 months, 3 to 6 months, and over 6 months, almost a third of responders. So over a half of patients are waiting longer than 3 months. Are you currently using SLT laser as first-line treatment? Half of the responders are doing so. That may be a reflection of some of the responders not prescribing or not choosing the first-line treatment. I don't know. Or it may reflect the lack of access and lack of penetration of SLT amongst our attendees. And then what is the biggest pressure when it comes to glaucoma? And this is can I just say this is not my question, because it's lots of different options from sort of different spheres of different metrics, almost, if you like. Very few people have problems convincing patients that laser's best. That's interesting. But they half of people did say all of the above. So keeping the pressure low, patient compliance, and convincing patients, all of those were to some extent considered to be important by half the patients. So I think that is interesting. So thank you. I have been trying to answer questions as we go along. There have been a number of questions there. There's a question that's come in specifically for Neil, which was around different measurements around IPCC, GAT, eye care. How are you juggling all of these various different mechanisms, techniques for measuring pressure? There are many more on the horizon. There are new aura devices, both for clinic and also hopefully shortly to be accessible for home monitoring. How do you switch between the two?
So So most of that, actually all of that follow-up from start to finish was from the Aura IOP-CC measurement. So we had a like-for-like throughout from pre-treatment, then they were treated on drops, and then they had laser, etc., and then post-laser. So there was a like-for-like comparison to sort of see a change in pressure. So we wasn't flipping between one to the other. The only time that happened was on the laser clinic day. That we're not making any decisions on that eye care measurement. That was solely done as a pre and post laser procedure pressure measurement, just to make sure that, just to check for a pressure spike. But again, you're using the same machine pre and post, so you have a like-for-like comparison on that one there. But no decisions are made on that treatment. I personally wouldn't make any decisions on the basis of an eye care measurement. Eye care, so Aura or GAT is my go-to measurements when I'm seeing patients in clinic. But the eye care one was just that measurement done by the nurse on the day of the clinic for the laser treatment, and that's mainly as a flow, because it depends on where you work and what the laser clinic setup is. We have a nurse. We're quite lucky to have a nurse that works alongside us when we're delivering the treatments. And the nurse does the prep and the workup, visions, allergies, etc., and the discharge as well. Once we've done the laser treatment, so that's just to look out for the pressure spikes. So that's, don't let that confuse you in terms of any decision making. So for that patient, it's all done on Aura. But then in clinic, I stick by the Aura and or the GAT. But the one thing that I do always mention with the Aura is always look out for the waveform score, the WS score, because if that's poor, then the Aura measurement is unreliable, which sometimes can be missed if you're in a rush or a hurry, or if it's not written down, if someone else is doing the measurements on that one. So the waveform score is important for that to be a good quality, for the measurement to be reliable on that. So hopefully that answered the question.
Brilliant. Well, thanks for it. Yeah, I think that did. Thank you. Any last closing questions from you, Sheraz?
No, not really.
No, I think that was pretty
there seems to be a lot of interest here in DSLT, and I think it seems to me that a lot of people are scratching their heads there. I would invite them to observe it in real life. Go to Moorfields or ourselves or anywhere there's an installation and see it for yourself. I think it's when you observe DSLT being done, it's quite compelling, and you realize it's actually a solution to a big problem that we have in the UK right now.
Yeah, and I think it hopefully, I mean, I hope that it will lower the bar to drop-free, drop-independent pressure lowering for the majority, which we've shown pretty conclusively in a number of different studies to be a powerful preserver of visual field loss, both for the Hydrus and the SLT. That if you can remove the patient component with laser or MIGS, you can really get whether it's through better pressure lowering or removal of the need for drops or a flattening of diurnal curves, whatever it is, it seems to give better visual field preservation. So on that optimistic note, I'll thank you guys for joining us and giving up the time of your evening. I look forward to seeing you at the UK's meeting soon. So thank you very much, and good night, everyone.
Thank you.